afternoon, everyone, and thank you for attending the State of the School Address for the University of Colorado School of Medicine. I'm the Dean, John Reilly, and it's my privilege to give you a summary of what's been going on here at the school and a look ahead as to what we have planned for the upcoming year. Now, when I gave this talk last year, it was my fervent hope that I would be giving it in person this year. And once again, I'm in an eerily empty Fitzsimmons building, delivering this to you virtually. And so you're going to hear some things in this year's talk that are remarkably similar to last year's talks, and hence this quote from Yogi Berra, it's like deja vu all over again. It's been an amazing year. At the time I gave this talk last year, we were just rolling out vaccines across the country. The healthcare workforce was being vaccinated, and there was a real sense of hope that this would represent turning the corner on this pandemic. Since that time, many of us have had the opportunity to become reacquainted with the Greek alphabet. And we've moved our way from Alpha to Delta to now to Omicron, with the impact that it's had on all of us, and hence working remotely again. This year and the pandemic has continued to shine a spotlight on a few things. One is that we are a divided society when it comes to how we consider scientific evidence. There are dramatically different points of view about vaccination, personal freedom of choice, and societal responsibility. We continue to see stark differences in outcomes for different parts of our population, which highlights some structural issues in our society and healthcare system that need to be addressed. Now, for those of you who don't want to sit through the whole talk, which I think will be about 35 or 40 minutes, I'm going to give you the punchline on the next slide here, which is, despite COVID, we've accomplished a lot. So last year when I gave this talk, I began by showing what we had outlined pre-COVID as our goals for the year, and how we had done at performing towards those goals. These were the goals we outlined last January, starting with vaccination, and you can see the rest here. Building a data science program, bringing on the new Anschutz Health Science Building with its associated vivarium facilities, working to create specialty and primary care practices in the city of Aurora in partnership with Salud, rolling out our new curriculum for the class of 2025, and opening a branch campus in cooperation with our colleagues at Colorado State University. We also we're embarking on chair recruitments. We're outlining a new approach to graduate students, and we're going to establish the Center for Health Equity. So how have we done? So first of all, I wanted to mention that in concert with our colleagues at the downtown Denver campus, we were designated as a Hispanic serving institution this year in recognition of the composition of the student body and our mission. Of particular interest to me, given my advancing age, is we were also designated as an age-friendly university, the first one within the University of Colorado system to get that designation. I was talking with my team over the past couple of weeks, and we remarked that we've made substantial changes in all three of our mission areas of clinical care, research, and education over the past year. And I'm going to walk through a few of those to illustrate those points. First of all, we welcomed 2 new department chairs, and we're honored 2 new distinguished professors. So I want to recognize Dr. Vineet Chopra, who is the new chair of the Department of Medicine, joined us from the University of Michigan this fall. I want to thank David Schwartz for his prior service as chair of the department and turning over a department in very good shape to Dr. Chopra. We also welcome Dr. Myra Muramoto from the University of Arizona. And similarly, I'd like to recognize and thank Dr. Frank Degree for turning over an exceptionally strong Department of Family Medicine to Myra's leadership. And we were honored to have two of our faculty deservedly honored for being named as distinguished professors, Dr. Judy Regensteiner, who runs the Center for Women's Health Research, and Dr. David Schwartz, in recognition of not only his leadership roles in the department, but his research contributions, particularly in the area of pulmonary fibrosis and gene and environment interactions in lung disease. So my congratulations to them both. So on the clinical care front, we've been busy. Many of you on this call already know that. We have had a record year in terms of clinical volumes. In fact, December of this year marked, in terms of billings and clinical collections, one of the busiest months on record for CU Medicine. We'll talk a little bit later about the COVID response this year. We have embarked on restructuring our community-based practices and moved to employ the staff who work in those practices rather than leasing them from our clinical partners. We've continued our telehealth initiatives, and importantly, we've continued serving the Medicaid population. Now, I wasn't here at the time when my predecessors planned to move out to this campus, but being a pulmonologist and given the prominence of Colorado in the pulmonary world, I had occasion to interact with a variety of faculty who were here then. And at that time, there was a lot of concern that with this move out to the old Army base, the patients weren't going to follow, and that building clinical practices was going to be a real challenge. And fast forward now, and we cannot keep up with the demand for our clinical services. So as anyone who's tried to make an appointment in some of our specialty practices know, we are busy and full and cannot always meet those requests in a timely fashion. And trying to improve that performance is going to be one of our foci for the upcoming year. Now, as part of our commitment to Medicaid, we're fortunate enough to participate in a federal program that was designed for faculty of public medical schools, designed to increase access to services for patients on Medicaid. And I want to thank Ann Fulbrigge and Tina Finlayson and Aaron Van Artsen for working in a very productive and collegial manner with our colleagues at the Agency for Healthcare Policy and Finance to implement a number of programs that have met this goal of expanding access to healthcare for Medicaid beneficiaries in Colorado. As many of you may know, about 23% of the population in Colorado is on Medicaid, as we're a Medicaid expansion state. And if you look at children in Colorado, roughly 50% of the kids in Colorado are on Medicaid. So it's a sizable and very important part of our population. And I'm proud of the efforts that we've had to expand access for them. You can see that we have increased our number of Medicaid patients served by over 23% over the 4-year life of this program. We have ramped up telemedicine visits, as you can see on the right-hand side of this slide, dramatically. I will show you in a couple of slides coming up what we've done in terms of educating the healthcare workforce across Colorado. And you can see that we've also had a substantial increase in the number of electronic consults we provided Medicaid patients and their physicians since financial year 20. I do want to say that there's a plethora of projects, more than 100 that we funded through this program, It supports a lot of staff, and it is a point of pride for our school and reflects the hard work and partnership with our clinical partners as well. And I will point out that a lot of the work that was done on e-consult and telehealth platforms, which started before COVID in the context of these programs, provided us a foundation where we were able to pivot very quickly when the COVID pandemic hit to meet the demand to move to remote for some of those services. So you can see we have over 102 unique investments. The majority deliver care to rural and frontier areas across the state of Colorado. More than half of our projects are focused on children, and more than 3/4 involve the use of telehealth platforms. And on the next few slides, I'm just going to call out 3 of these programs of the 102. One is the Connections program for infants and families. We'll talk about Echo Colorado, and then our new dermatology clinic in Aurora. So the Connections program for high-risk infants and families, as you can see on this slide, is designed to support families in their totality who are either in the midst of high-risk pregnancies or have recently delivered medically complex infants, or sadly have lost a child either late in pregnancy or shortly after birth. You see the quote on the bottom of this slide from a former patient here. This is a program that has met an unmet need and has been greatly appreciated by its participants. Echo Colorado is a education platform that's focused on the primary care workforce across the state of Colorado. As you can see, practitioners in over 90% of the counties in Colorado participate in this. It is a case-based curriculum that is precepted by specialists and faculty drawn from our faculty and also from the community. You can see here that there were a tremendous amount of sessions offered this past year, many participants across the state of Colorado, and many identified it as an important source of information, keeping up to date with the changes on therapeutic and diagnostic options related to the COVID pandemic, in addition to other topics that have been covered over the past several years in the ECHO program. And I want to call out the dermatology practice that the Department of Dermatology and CU Medicine started here in Aurora. It has a particular focus and expertise for patients with skin of color, and it serves the Medicaid population. It, in fact, is the only site in Colorado that offers electrolysis services for transgender patients who are Medicaid beneficiaries, and I think is emblematic of our commitment to expand access to underserved populations in the city in which our campus resides, which is Aurora. On the education front, it has been a busy year. We talked last year about the plan to implement a new medical school curriculum. I want to congratulate Dr. Shanta Zimmer and her colleagues on the education team for doing that, despite the challenges of not being able to have everybody at work over the past year, having to interview all the applicants remotely. And I want to congratulate Dr. Jeff Suhu and his team for handling an overwhelming flood of applications, as I'll show you on an upcoming slide. We also opened a new branch campus in Fort Collins in partnership with Colorado State. We have 12 students up there now. I want to thank Dr. Suzanne Brandenburg and her team for their efforts in getting that campus organized and open. And throughout all this, we have had in-person classes, moving to virtual education, moving back to in-person classes, moving back to virtual education, back to in-person, and now we're back to virtual for another 2.5 weeks. This has put a tremendous stress on the staff here, and I want to recognize them for their efforts in that regard. Last year at this time, we talked about the desire to reorganize our PhD programs and make them more closely aligned with departments within the School of Medicine, provide increased mentorship and oversight of the programs. And I'm happy to say that we implemented that start effective in July. I want to thank Dr. Angie Rivera for taking on the new position of the Associate Dean for Research Education and overseeing that transition. There are still some bugs to work out, but we are well on the way to this new organization. And at the same time, we are keeping our commitment to increase the number of graduate students supported each year coming in, ramping up over the next 4 years for a total of a 50% increase in the number of graduate students. If we look ahead, it's hard for me to believe since we did this my first year here 6 years ago, but we are coming up on our time for reaccreditation with the Liaison Committee for Medical Education. In the short term, we are working on continuing to secure an adequate number of clinical sites for the longitudinal integrated curriculum, acknowledging that we have what our education colleagues refer to as the bulge. Since in the new curriculum, the clinical rotations begin in the second year. In the hybrid curriculum that our current second year students are in, it begins in the third year. So we will have a year when we have both second and third year students in the clinical training environment. There is a new and substantially increased in size simulation center in the new Anschutz Health Sciences building that will come online this year. And we will continue our commitment to cast a wide net to recruit the most talented, diverse medical school class that we can. On the research front, a lot has been happening as well. With the opening of the new Anschutz Health Sciences building, we will be bringing a substantial increase in our vivarium space on board to the tune of approximately 29,000 square feet, which I think will address what have been one of the rate limiting research resources on this campus. As I'll show you coming up, we have a continued increase in our extramural grant funding despite all the challenges of the COVID pandemic. I mentioned our graduate student reorganization and an eventual 50% increase in the number of graduate students supported on this campus. I want to thank Suzanne Ruderman and Peter Buttrick, the unidentified researchers for fear of reprisals who participated in walking the wet lab space on this campus to identify space that is being optimally used, identify space that is being overused and requires expansion, as well as unutilized and underutilized space. For those of you who saw Peter Buttrick's presentation at the School of Medicine Exec Committee, you saw the statistics that the unutilized and underutilized space far exceeds the amount of overutilized space. And we are going to embark on a program to reorganize that space in a way to make it available for the ongoing faculty recruitments that we have. In recognition of the impact of the pandemic, particularly on our early career research-oriented faculty, last year we had extended the tenure clock by a year, and this year we extended it by another year. I want to emphasize, however, that this does not mean people who are ready for promotion need to wait any additional period of time before submitting their dossiers and embarking on the promotion process. It just provides people an opportunity for more time should their productivity have been adversely impacted by the COVID pandemic. And speaking of early and mid-career investigators, this slide demonstrates both our K awards seen here in the gold and our training grants, primarily T32s, but some others as well, in the black, showing that our early stage investigators have remained competitive and been able to secure career development awards even through this pandemic period. So it's hard to remember what life was like before COVID on this campus. The past 2 years are kind of a blur, at least for me, and I think for a lot of us. So I thought it'd be worthwhile to take sort of a whirlwind tour of what's happened here over the last 5 years, and then wrap up with our plans for the upcoming year. So over the past 5 years, and I'm just going to hit a few of the center grants here, so my apologies in advance to people whose grants don't get mentioned. We renewed the CTSA grant. Ron Sokol and his team once again renewed that grant, and in fact are gearing up for a competitive renewal submission later this spring. Rich Schulich and his team renewed our Comprehensive Cancer Center Support Grant with, I think, the best priority score that we have ever had in such a renewal. Paul McLean and Dan Bessetson and their team renewed our NORC, our Nutrition and Obesity Research Center grant. We have a newly funded SPORE grant in head and neck cancer, and my thanks to XJ Wang, Antonio Jimeno, and Sana Karam and their colleagues for persevering and seeing that application through successfully. And my thanks to Lori Sussel and Jane Roosh and their team for our newly funded Diabetes Research Center grant. We had one that lapsed about 15 years ago, I believe, and to obtain a new one in this funding climate is an accomplishment that we should all be proud of. And just to highlight here, here's a map of the CTSA sites across the United States. You can see that there's not a lot in the Rocky Mountain West here. Similarly, if we look at the Cancer Center grants, particularly in blue, the Comprehensive Cancer Center grants, you can see they are largely clustered on the coast, and we are the only show in town for the state and for a significant radius around here. And I think this highlights our importance as an academic institution, an academic medical campus in the Rocky Mountain West. So as promised, here's the whirlwind tour. We are now almost 10,000 employees, up 25% over the past 5 years. And we are now almost 5,000 faculty, up almost 40% over the past 5 years. Our budget is now approaching $2 billion for the School of Medicine, up about 28% over the $1.5 billion in 2017. Our grant funding has increased by 30% in that period of time, and our NIH grant funding in an exceptionally competitive climate has increased by 36% over that period of time. The number of patients we served is now past 600,000, which is a 17% increase. And the number of visits is now over 3.5 million, which is a almost 30% increase over that period of time. Our medical school applications have doubled over the past 5 years at a time when the national applicant pool has gone up by 17%. So we have far outpaced the national trend. Our philanthropic dollars, this excludes foundation grants, has increased by an amazing 183%. I want to thank Scott Arthur, Jim Hodge, and the entire team in the CU Foundation on this campus for their partnership and hard work to make this happen. And that is reflected in the increased number of endowed chairs that we now have on this campus, increasing by more than 30 over the past 5 years. If I updated this slide to be accurate through January of this year, that number of 122 would be now 130. So a substantial increase in the number of endowed chairs over the course of that time. So that is an amazing story and an amazing trajectory. And so if things are so great, why do we all feel so bad? And it's been a tough time. So the last time I gave a talk like this, at this point in the talk, I used a quote from Charles Dickens' A Tale of Two Cities. Many of you are probably familiar of it. It was the best of times. It was the worst of times. So I thought I'd move from the 19th to the 20th century. So, and I'm a music guy, so I'm going to use song lyrics here. So this is from Bobby Gentry's Ode to Billy Joe. There was a virus going around. Papa caught it and he died last spring. I think that encompasses, even though this was written in 1967, what we're going through now. And now Mama doesn't seem to want to do much anything, which I think speaks to the mental health crisis that's going on in this country. COVID. Our faculty have provided outstanding care during COVID. And I would say if you were in Colorado and you got sick with COVID, you wanted to be in University Hospital. And there are multiple examples of people driving by other hospitals to bring their loved ones to University Hospital because of the widely held perception that the care our faculty and our partners at UC Health have provided has been outstanding. And the data support that. I want to particularly recognize UC Health and Liz Concordia, their CEO. They have been a leader across the state since the beginning of this pandemic. Early on, guaranteeing full employment and full salary to the workforce at a time when everybody was concerned it was going to be a financial catastrophe, this pandemic. Being a leader in implementing a very effective, highly efficient vaccination campaign when vaccines became available 14 months ago. Taking an early stand on vaccine mandates at a time when it was viewed by many as, quote, a risky, unquote, thing to do. And in generally gearing up to meet this pandemic. It's a source of pride that we've been able to partner with them in the greater Denver metro area in the response to this pandemic. And I think everybody at UC Health should be extremely proud of the job they've done during the pandemic. At this time last year, we had this discussion about the fact that kids weren't getting sick. There was no flu, there was no RSV. Everybody talked about, remote schooling and masks, deferring the respiratory season. And there was a real discussion in epidemiologic circles about whether we were just going to skip a year, whether the winter of 21-22 was going to be a really bad winter, or whether we would see cases at other times. And what we saw was the early arrival, of RSV this year. So these are data from the Children's Virology Lab. These are the RSV isolates in 2019 here in gold, and you can see the usual rise in the fall extending through the early winter and dropping in the spring of 2020, and then nothing for calendar year 2020, and nothing through June of this year, and then a very early rise in RSV, which has not abated. And the result of that has been, after no admissions for respiratory illness in 2020, or virtually no admissions, a prolonged and early starting respiratory season for Children's Hospital Colorado this year. And as you've all read in the papers, kids are experiencing more COVID admissions during this Omicron wave than they did with the prior variants. So to quote another song lyric, here's from the Beatles, people are tired. People are really tired. And a lot of people are depressed, not just in the medical workforce, but across society in general. And we look at the factors that contribute to that. One is everybody's working hard. We have record clinical volumes. Our hospitals are full, both children's and university hospitals, as well as Denver Health, are functioning at very high capacity. And things that work pretty well when hospitals are 85 and 90% full don't work so well when hospitals are 102% full. Our emergency rooms are seeing record volumes, which have forced some of them to go to emergency standards of care. And people are leaving the workforce. So every healthcare system in Colorado is looking for nurses and respiratory therapists and phlebotomy technicians and radiology technicians. And many hospital systems have had to curtail certain services because staffing is just not available. The other thing that's different than a year ago, I think, is the change in dynamics with patients. The patients who are in the hospital now with COVID are still predominantly unvaccinated patients. Many of them have no interest in being vaccinated and feel that our approach to COVID is not scientifically based, part of some conspiracy theory. Many want untried or therapies that are proven not to be effective, like ivermectin, and that has led to a significant increase in the number of confrontations between patients, families, and our medical staff. At the same time, there is some resentment among people working in the healthcare sector that we're working really hard and people are burning out because the choices people made not to get vaccinated. That the combination of those two dynamics has meant that it's a very different experience for a lot of us to take care of patients during this wave. And then we have this new factor that we have people who got vaccinated, who got boosted, who need other medical care, whether it be joint replacements or outpatient visits, and their care is being deferred because of the stress being put on the system by people who are unvaccinated, and these patients are understandably not happy about that. I think another, particularly with the demographics of our faculty, factor contributing to this is the fact of what our kids are going through. It's been a very challenging 2 years for education, for social interaction. You all have likely seen the public declaration by Jenna Hausman, the CEO of Children's Hospital of Colorado, that the mental health, pediatric mental health is now at a state of public health emergency. On many days in the Children's Hospital emergency room, the leading diagnosis of the children and adolescents in the emergency room is suicidal ideation. This is a substantial qualitative change in the landscape. And the social isolation. We've learned over the last 2 years that much of what we can do in person some of which also can be done remotely. But it's also highlighted the fact that the informal interactions we have people in the workplace on a regular basis are a source of creativity, a source of professional satisfaction, and enable us to get work done more efficiently. Being isolated and working remotely has placed a toll on people. So prior to the COVID pandemic, given the rate of growth in our faculty and the feeling that we needed a more cohesive approach to leadership development, we began to formulate plans to create a new senior position in the School of Medicine, a senior associate dean for faculty development. We put this on hold during the first year of the pandemic because it was hard to imagine recruiting senior leaders, but decided to move ahead earlier this year. We're gratified that we had an extremely strong field of applicants, and are hopeful for naming a new Senior Associate Dean for Faculty Development and Workforce Development in the near future. That person will also have the title of Chief Wellness Officer, and we will work to stand up programs that not only provide our faculty with leadership development, but also produce a meaningful improvement in the workplace to improve their overall wellness. That alone is not going to be enough to address all these things. It's my hope that Omicron will do what vaccinations alone did not do, which is get us to herd immunity and move us from a pandemic situation to an endemic situation so we can go back to a more normal approach to our work. So in closing, I'm going to wrap up with our plans for 2022. Leadership recruitments. I just mentioned the Senior Associate Dean for Faculty Development, Chief Wellness Officer position. We have active chair searches going on for new chairs in the departments of radiology, dermatology, pharmacology, and physiology and biophysics. The latter two are fairly far advanced. The former two are just getting underway. I want to express my appreciation to the board of CU Medicine for making the decision to fund an endowed chair for the chair of the Department of Dermatology, which will help us in our recruitment efforts, as well as funding an endowed chair for one of the two basic science departments that you see listed here. We will stand up a new Department of Biomedical Informatics this July on schedule. We're going to do a major, what I'm calling a spring cleaning of our laboratories. The so-called LER areas, the longitudinal equipment rooms, those wide corridors, have a large population of outdated equipment and a surprisingly large number of empty boxes on shelves. We're going to clean all that stuff out. I personally had the opportunity to see an ultracentrifuge that was last run in 2012. Looks really nice, but probably doesn't need to be in our laboratory buildings anymore. And that's one very small example of a very large issue. And we will be gearing up to work with our research colleagues to identify that surplus and outdated equipment, move things out and reorganize those spaces so that they're more functional. As I mentioned earlier, we are going to consolidate our underutilized and unused wet lab space to create blocks of laboratory space to use for faculty recruitment and when justified for program expansion. And we will be bringing online our new vivarium facilities. Now that we have a certificate of occupancy for the new Anschutz Health Sciences building, we will begin the move-in process for programs there, which will take us through most of the spring, and then have a series of moves after that to relocate certain programs into the space vacated by the programs moving into the Anschutz Health Sciences building. As I mentioned earlier, we're going to have a concerted effort this year to improve the efficiency of our practices, make them a better experience for both patients and practitioners, and to improve patient access so that everybody who wants to see one of our highly qualified faculty has the opportunity to do so. We remain committed to establishing primary and specialty care practices in the Aurora community. Last year at this time, we were in conversations with Salud about a joint venture to do this. It became obvious over the past several months that we were going to be better able to meet our goals, and they would be better able to meet theirs if we pursued our paths independently. We have been working with a real estate developer and Mayor Mike Kaufman of Aurora and his staff to identify an appropriate location in an underserved area of Aurora to site our primary care and specialty practices, as well as our Center for Health Equity, and in partnership with the community, other programs that address the social determinants of health. We remain firmly committed to reaching out to the underserved zip codes around this campus and provide them with access to healthcare that they need. And we will continue to support and volunteer at the Dawn Clinic at Dayton and Colfax, as we have since its inception. We will initiate the search for the first director for the Center of Health Equity and get that center underway. The job description has been written, and we will be starting recruitment soon for that. Our plan would be to ideally locate it on the campus in Aurora with our new primary and specialty care practices and other community programs. And hopefully, next year I'm giving this talk in an auditorium, and we will have had people back in the workplace working together. Still some work being done remotely. I don't think everybody will be back to in person 5 days a week, but I think most of us would like to spend more time on the campus than we've been able to over the past 2 years. And with that, I am going to stop my screen sharing. I'd be happy to answer any questions if people would put them in the Q&A. So the first question in there is, with Omicron cases increasing, will campus continue to be remote past January 24th? I don't know the answer to that. We are committed to trying not to have it be remote past January 24th. The prevalence rate, at least on testing, seems to have plateaued, albeit at a very high level. Inpatient cases of COVID are inching up, but not at the same rate that one would have expected with a prior variant and our case positivity rate. So it's our hope that Omicron will crest in the month of January, and we can get people back here before the end of the month. Next question is, what is the feedback from medical students on the new curriculum? So as part of the implementation of this new curriculum, there have been a concerted strategy to try to obtain immediate feedback from a broad variety of students. And I would say that the majority of the feedback has been positive. When there has been criticism, it has been constructive and has allowed us to contemplate changes in the curriculum for next year's class. But overall, people have been very positive about it. It's required a tremendous amount of work from our staff and faculty involved in education to implement this. And I want to emphasize that we're in the first year of a 4-year phase-in project. So what we have is the first year of the new curriculum. So we're running 2 curricula side by side, a hybrid curriculum for students who are in the second year and above, and the new curriculum for students in the first year. And obviously that will march up by a year each year. As I mentioned earlier, we are looking at the likelihood that there are more students in the clinical arena at the year when those 2 curricula overlap between the second and third year students. There's a question in the Q&A about the medical school goal for the percentage of medical students who are residents of Colorado to be admitted. We don't set a firm goal for the percentage of students who are from Colorado. It has varied over the years from 70% to 45%, a little lower in more recent years as we've had more applicants from across the country rather than the regional predominance that we might have had a decade ago. We look to take the most highly qualified applicants. Statistically, applicants from Colorado are more likely to be admitted than applicants from out of state. I have the belief that once a student spends 4 years here, they are likely to want to remain in Colorado and become Coloradans. But we don't have a quota or an explicit quantitative goal for the proportion that are from the state. So next question is, what has surprised you about this campus and the School of Medicine in the past 5 years? I continue to be surprised that we have not plateaued. Every year I say to myself, we can't keep growing at this rate, and we do. I wouldn't say this is a surprise, but one of the sources of pleasure of this job is that as we have grown, we have had the opportunity to offer faculty positions to our highly qualified trainees who want to stay. And we've been able to attract world-class talent from not only across the country, but from around the world to come and join us on the campus. This has been a challenging 2 years, but I have made this remark to my leadership teams and my wife so much that they're tired of hearing it. But I have the best job in the University of Colorado, hands down. It's based on an extremely strong foundation that was created by my predecessors and the collective efforts of our faculty and what I think is a unique faculty culture of people who are not only personally ambitious, but committed to the collective good on this campus. The next question is here, could you comment on faculty performance ranking for the annual vals? And do you think most should meets expectations even this challenging year during which most faculty outperform what they would do in normal years? Well, there's an underlying assumption in your question which is incorrect. And I hesitate to say that publicly, but I will. Most of our faculty do not get meets expectations. If you look at the distribution of annual performance evaluations, it is heavily skewed towards exceeds expectations. And that has led me in my more cynical moments to remark that if everybody's exceeding expectations, perhaps we should raise our expectations. But in all seriousness, I have to say that the faculty as a group, and I know the chair share this sentiment, should be very proud of how they've risen to the challenges of the past 2 years. And I would be surprised if many of them get, say, meets expectations on their evaluation. Okay. How will UNC trying to open a public DO school affect UC Health in Northern Colorado? I don't think it will affect UC Health. It will put in the steady state, since they have articulated a vision of 150 students per class. And if they adopt a traditional curriculum in which 3rd and 4th year students are largely doing clinical rotations, it will put 300 more medical students into the clinical environment across the state of Colorado. I think the data would support the fact that the clinical environment across the state of Colorado will not support 300 more students in high quality clinical rotations. And it would be my prediction that they're going to have to look outside the state for some of those placements. I know they have been in talks with Banner. I cannot speak for UC Health, but I will tell you that they have affirmed that they have a strong commitment to providing meaningful educational opportunities for our students and residents. And I don't anticipate that that commitment will change with the opening of a new DO school. Next question, is there a plan for salary equity among rank and department and sections? There seem to be ongoing large disparities. So there are differences in salary across departments and sections, and those relate to largely to differences in the income potential of different specialties. It is a fact. We can debate about whether it's justifiable or not, or desirable or not. It is a fact that certain specialties enjoy higher income levels than other specialties. As a rule, dermatologists make more than family medicine doctors. Neurosurgeons make more than general medicine, primary care physicians, or hospitalists. I feel strongly we need to be competitive financially in the marketplace to attract the best talent. It doesn't mean we need to pay the most, but we cannot be 20 or 30% below the mean of the market. And that means that we need to be competitive in salaries for cardiologists and oncologists and surgical oncologists and radiation oncologists and otolaryngologists and endocrinologists, et cetera. And what being competitive means varies a lot from specialty to specialty. Within those groups, we do look on a regular basis across rank and years in rank to make sure that there are not salary discrepancies within what we think are comparable groups. And over the past several years, I think we have largely, maybe not completely, but largely eliminated salary discrepancies that were not justifiable by differences in performance or job responsibilities. So I think many of the disparities that this questionnaire refers to is a function of the way American medicine is structured and differences in compensation across different specialties. As a single institution, we do not have the economic power to change those forces. Okay, current landscape, complexity, burnout, moral injury, wondering what system level interventions do you anticipate? Well, I think we're going to have to do this is a question from Dr. Neumeier, who I want to thank for her efforts in medical education, by the way, who raised the issue of burnout and moral injury and what system level interventions will need to be implemented. I think it's going to have to be a multi-tiered approach. Some will be at the system level, some will be at the more local departmental level. What we need to recognize that the specific workplace issues may be different from department to department, depending on the environment that they work in, but that we need a more cohesive coordination among those programs and some common principles than what we have had to date. It's too early to go into specifics, but one of the finalists that we're negotiating with for this job has articulated a vision that incorporates both system level and more local interventions. It will require a substantial investment by the School of Medicine, and we are prepared to make that investment. Our faculty and staff are far and away our most precious resource, and their hard work has enabled our financial performance that has given us the resources that will allow us to invest in those programs. So more to come over the next couple of months on this, but it is a priority for the upcoming year. Another question about salaries. I'm going to summarize this. This refers to the issue of salary compression, that new recruits being brought on at salaries that reflect the current marketplace may mean that they're paid the same or more than existing faculty. We have mechanisms to address that. And it is up to the division chiefs and department chairs. But when there are equities, and this is particularly relevant under the new Equal Pay for Equal Work Act in Colorado, when there is this kind of compression that occurs, we do approve salary adjustments to deal with that appropriately. Question from Stan Zeffler about attempt to gather the information on various grants, community actions, and clinical support efforts provided the community to more actively address the university contributions to the mission of addressing health equity. Complicated answer to that question. Each of our healthcare system partners is required every 3 years under the provisions of the Affordable Care Act to do a community needs assessment and to provide an annual community benefits report. One of the active dialogues in the state of Colorado is actually what constitutes a community benefit, because the state has a different definition than the federal government as to what qualifies for community benefits. We have begun to make efforts to codify the grants and community interactions and clinical support. But to say that we have an accurate total picture right now would not be accurate. There are a lot of programs going on in which our faculty, staff, and students interact with various community groups, and doing an accurate inventory of that is an important activity, but one which is incomplete at the current time. Will there be merit increases in financial year 2023? Technically, that's up to our Board of Regents. But I would be very surprised if there was not merit increases for fiscal year 2023. From an economic perspective, we were under the most stress in the first 4 months of this pandemic. Our financial performance over the past year has been good, and we certainly are in a position to support merit increases. And I would anticipate that the regents would approve a merit pool increase for next year, but that is their decision to make. All right, we are at the hour. I'm not seeing any more questions come into the Q&A. So I want to close by thanking all of you for your hard work over the past year, and for being the driving force behind the incredible trajectory that I tried to provide you some examples of during this talk. It's a tribute to the faculty and staff in the School of Medicine that we continue on this trajectory, even in the face of incredibly trying circumstances. The commitment to the common good, both in our patients and our students and in each other, continues to be a source of great pride for me, and should be for you, because it's a distinguishing characteristic of this school. So I want to thank you for all your efforts. I want to wish you a happy and healthy 2022. Fingers crossed for being back to normal later in the spring. And I look forward to working with you over the upcoming year. Thank you.